Digestive system. So we talked about the regulation. Now we got to talk about anatomy just a little bit. I mentioned that digestive system, it's actually a great illustration here. It's your digestive system, the hole. You see? That little hole? That's your entire digestive system. The hole starts in the mouth and ends in the anus. It's very, very convoluted way. But if you think about it, I read the study. It's a very interesting study. As far as I remember, what they did, they were trying to collect some microbes on the thread. So the person swallowed the capsule, and this capsule made its way all the way through the alimentary canal with a thread attached to it, very thin thread. It's pretty much the thread was hanging out of the mouth all the time. Well, obviously it was going one way, you know. But technically you can do it if you have a thread long enough. You can have one end in the back and one end in the front. Okay? They wanted to collect some microbes in the intestine, as far as I remember. Some sample, like different changes or something. It was, now they actually, they started to do the tiny cameras, which are HD cameras. You can actually swallow them. And then they have a light thing, so it goes through the alimentary canal and they can watch it. Actually, so, and they can record it in HD, and you like can have 60-inch TV watching it, which most of the time is not a very exciting thing to watch, you know, until it gets into the intestine. Then you can find some really nice stuff. So organs that comprise the alimentary canal are the primary endocrine organs. Primary digestive organs. So we start with what organ? The mouth. With the mouth, get into the before esophagus. Pharynx, throat. Now from pharynx we go to esophagus. From esophagus we get into the stomach. From the stomach we start our travel into the small intestine, which can be separated into three parts, fairly small duodenum, then you have jejunum, and then you have ileum. Then after the long small intestine, you enter fairly short large intestine, which culminates in a part called rectum. Okay, large intestine has several parts: cecum, ascending, transverse descending, colon, sigmoid colon, rectum, and rectum opens up outside through the anal orifice. We call it anus. Okay, so that's your primary digestive organs. They comprise that whole. Secondary digestive organs, not the part of the whole, not the part of the canal. Huh? Say again? Like gallbladder, yes, gallbladder. Anything else that is not a part of the canal but participates in the digestion. Pancreas, very good. So pancreas, gallbladder, something else. Liver, yes, liver. Something else. Huh? Spleen does not participate in digestion. Something that you produce, yeah, well, that you can feel like you produce. Yeah. So salivary glands, yes. Big salivary glands here. Tongue is a tricky part. Well, technically it's a secondary organ, because it's a part of the mouth, it's in your mouth, but people without a tongue can still eat. Okay. Well, the people without stomach can also eat. Anyway. It's considered a secondary digestive organ. Yes. Okay? So all these organs comprise a system, essentially. Now, organs of the alimentary canal, not primary digestive organs, not all of them, but a lot of them, organs located in the peritoneal cavity are covered with the peritoneum. Peritoneum can be, when it covers the organs, it's visceral peritoneum. You can see visceral peritoneum here. See? So this is visceral. It's a membrane, serous membrane that surrounds the organs. Produces serous secretion like watery secretion. Why? What's the purpose of that watery secretion? Lubrication, yeah, because that the guts, quite literally, they rub against each other. You want them to be lubricated. Okay? The parietal peritoneum covers the walls of the peritoneal cavity. Does that make sense so far? You can see that this is essentially a continuous membrane. See? I can circle this whole thing and I never had to take it off. Right? So this is a continuous structure. Parietal and visceral peritoneum are continuous. Now, mesentery recently was announced to be an organ this year. Well, actually end of last year. Mesentery was finally, mesentery is the membrane, okay? So, let me show you. So this is mesentery. This is dorsal. This is ventral. So mesentery kind of attaches the organs in the gut, small and large intestine, to the walls of the abdominal cavity, either to the ventral or dorsal abdominal walls. Does that make sense? Otherwise they would just be flopping all over the place. So mesentery for a long time was considered to be not the organ, just the membrane. American Association of Anatomists announced that it's organ now. So it's got a promotion. That's it in terms of change. Before we didn't acknowledge that it's an organ. Now we do. Now, interesting thing is that sorry about that. So it's a bunch of, so it supplies, it provides the pathway for blood, vessels, and nerves to the intestine, okay? It also contains a lot of lymph nodes, mesenteric lymph nodes, because it's essential. Gut, intestines, is the important entry portal for infections, if you think about this, right? You get a lot of intestinal bugs. It also accumulates fat. Turns out that part of the mesentery, which is called a greater omentum, it's like an apron that covers your intestines from here. Have you seen men, the belly like that? Everything else is fine, pretty much, but the belly is like that. Don't flatter yourself. Don't flatter yourself, no. I mean, like this. When they like, huh? Say again? Well, it's probably true, yes, but that accumulation of fat is called an abdominal fat, and it accumulates specifically at the greater omentum. So it's like a fat apron. And it turns out that fat that's in the abdomen is much, quote-unquote, worse than fat under the skin. Okay? It was shown that, say, if you have two people of the same weight, with the same body composition in terms of the proportion of fat, say 30% of fat by mass, which is a lot, okay? But if one person has this fat in the abdomen and another under the skin, person with a fat in the abdomen will be at higher risk of cardiovascular disease. And we still, I mean, we can see like inflammatory cells and this and that, but we don't really know why is the difference. What is the big mechanism? Okay. Some of the organs of the alimentary canal are retroperitoneal, which means they are behind the peritoneum. Okay, right here, for example. So that's peritoneum, and this is retroperitoneal organ, like ascending or descending colon. Kind of move behind. All right? Pretty much most of the GI tract share the structure of the wall. Okay? I mean, there's several layers, except probably for the mouth, which is slightly different. Other than that, starting with esophagus, the structure is very similar. There are slight variations, which we will mention, but generally speaking, the wall of the GI tract consists of 4 major layers. The innermost, the deepest layer is the mucosal layer. Now, before we move any further, this opening, we call it a lumen. Lumen, okay? I'm going to use the word lumen. Lumen is its internal space, lumen of the intestine, lumen of the blood vessel. Does that make sense? The word lumen, it's a term. So, if we would imagine ourselves walking through the lumen of the intestine, the only thing that we will see will be epithelial cells. You see the thin layer of epithelial cells here. Okay? Next to the epithelial cells is lamina propria, which is a areolar connective tissue that houses a bunch of immune organs, so-called mucosa-associated lymphoid tissue. Okay? That makes sense? Because that's the first place where pathogens that you are quite likely to ingest. That's the first place where pathogens will try to break through. That mucosa-associated lymphoid tissue allows some protection. In the thin layer of muscles, muscularis mucosae, it helps in peristalsis. Another function of lamina propria is to house the blood vessels, like little capillaries and lymphatic vessels. They absorb nutrients from the lumen of intestine into the blood. Does that make sense? Good. Next layer is submucosa. It's a pretty boring layer. More of a structural function. Dense connective tissue, blood vessels, nerves, other lymphoid structures. Then, you've got third layer, the muscular layer. So muscular layer consists of two types of smooth muscles arranged in different way. The circular smooth muscle and longitudinal one. So if we look at the alimentary canal, that will be circular, that will be longitudinal. You can imagine that when you contract circular muscles, you can change the diameter of the lumen. When you contract longitudinal, you can change the length. So it's when you contract circular, it's like squeezing the paste out of the tube. Okay. When you contract longitudinal, I always have troubles with explanation of this concept. You know, like when the swimming trunks, they sometimes have these little laces that you tie, and God forbid these laces get lost, like get all moved all the way, so you have to pull them back. So how you do it? You squeeze the head of the thing at the end of the laces through that tunnel, okay, and try to pull the trunks along the legs. That's what your longitudinal muscles do. They kind of move, sort of, your intestines relatively to the food. Okay. Now, of course, it's not separated activities. Those activities are combined. And when they're combined, we produce that peristaltic movements. Okay. So far makes sense? The muscular layer contains the nerves. Okay, plexuses, nerve plexuses. They regulate the muscle activity. Make sense? Like through the sympathetic, parasympathetic regulation, or even through local reflexes. Of course, you know, sometimes muscles form sphincters. You have several sphincters. You have a sphincter at two ends of esophagus. You have a sphincter between esophagus and small intestine, between small intestine and the large intestine, and of course at the end of the large intestine. So everywhere you have to control the movement, the passage through, you have a sphincter. And finally, very boring serous layer right here. It's a serous membrane, serosa, serous membrane, produces the fluid, attaches your alimentary canal to other structures. That makes sense? Any questions regarding the general idea of those four layers? You have to know what the function of them. So this table pretty much summarizes the function. We're going to talk, of course, about specific properties of these layers way more when we get to particular organs, because organs have slight differences. We'll mention all of them, but that's the you have to keep it in mind. Like with endocrine system, we keep in mind about negative feedback, okay? With this, we have to remember anatomically we have mucosa, submucosa, muscularis, and serosa. Right? So we're going to start with the mouth. Two major activities that mouth does is chewing, using teeth. What else do we use when we chew? Tongue. Yes, tongue is extremely important. Okay, and chemical digestion. What chemically digests food in the mouth? Saliva. Yes. Okay. Now, anatomically, you would be surprised. Anatomically, mouth has so many things to talk about. First, this cavity here between your lips, your gums and teeth, and your cheeks. So that's where I put my tongue down. Okay, this is called vestibule. Okay, like, you know, when you walk in the building, there's a vestibule. Okay, it's vestibule. Now, the proper oral cavity is behind it. Proper oral cavity is where your tongue is. It's pretty much delineated by your teeth. Does that make sense? Okay. The roof of the cavity is the polati. There are two polatis, the hard, formed by maxillary and palatine bones, and the soft polati, which culminates in uvula. I don't know, when I was a kid, and I opened up my mouth and I looked at it in the mirror, saw the little thing dangling in the back of my mouth, and I was always curious, why the hell do I have this thing? It kind of looks wrong. Turns out it's really a functional thing. When you open your mouth and you have like this little dangling thing, that's uvula. Okay? Polati, tongue, cheeks, they all have a lot of taste buds. That's why the food that is tasty, like pizza, is called highly palatable food. Okay? Uvula. When we swallow, it closes your nasopharynx, which is a fancy name for nasal cavity. That's why when you swallow, your food doesn't go into your nose. And that's why when you cough while eating, food will come out of your nose. Because you have two conflicting things, swallowing and coughing. Swallowing closes nasopharynx, coughing opens it. Does that make sense? Fauces. Now, fauces, it's not, it's an anatomical term, but it separates the oral cavity, okay, from pharynx. So fauces is like an arch, okay? That makes sense? So you can see separate arches, the palatopharyngeal arch in the back, palatoglossal arch in the front. Few structures that you can study them yourselves. First of all, gums, of course. Okay, your lower lip is attached to the gums by the inferior labial frenulum. Labial means lips, right? Inferior in the bottom. Well, surprise, upper lip attached by superior labial frenulum. Your tongue is attached to the bottom of the oral cavity by the lingual frenulum. Tonsils. You have palatine tonsils that you can see here and lingual tonsil. Tonsils are accumulations of the lymphoid tissue which protect you from infections. First line of defense. When they get inflamed, you get a disease that is called tonsillitis. And they get inflamed when you have like constantly microbes coming in. Your immune system cannot completely eliminate them, so they continue fighting. It's a fighting and fighting and fighting, and it, you have sore throat pretty much. Okay, and like white exudate, and it looks bad. And they can remove them. I know how they do it here. I know how they do it back home. You give you local anesthesia, take a scalpel, do almost circular cut around the tonsil. They put a little loop and pull it out. And then you can eat as much ice cream as you can. And also other people can tease you, coming over and telling you, say mama. You cannot speak for about 3-4 days. You pretty much have no voice. Oh, it's really, really painful to say something. Huh? Probably so. Probably so. It's probably will be more disfiguring just to stick the cauterizer and just burn this thing out. Unless you use like this, burner, like industrial one. I think they can do it, yes. But I wasn't when I was a kid, I was in a hospital and we had a guy who got his tonsils removed. And it was, a day didn't pass without 15 people approaching him and telling him, say mama. He, at a certain point, he was really mad at us. So, and finally you can see the tongue, okay? So tongue, we talked about the functions of it in AP1. Taste, of course. Not only taste, though. It's also mechanical digestion. It moves the food in your mouth. It's really important because, remember we talked, food in your mouth forms a bolus, like a chunk that you swallow that. Okay? So tongue helps to form it. There are different types of taste buds. The foliate, well, not taste buds, papillae. Foliate papillae, the valate papillae, and fungiform papillae. So fungiforms are here. That's not the ones. That's the valate papillae. Okay, different papillae, just different shapes. Any part of the tongue can sense any taste. It's true. So it's not like you have sweet here and bitter in the back. Every part of the tongue can taste all the papillae or papillae. The what? Great question. I don't really know. I should check. I have 2 experimental animals that are about to enter that age, so I can check. It will take a while though. At least I can compare them and me. I don't know. That's a good question. I don't have an answer. And of course, tongue is important for speaking. People without tongue cannot speak. Salivary glands. My wife looked at my slides and she said they're very dense in terms of the text. Well, here's the thing. I'm not reading them. It's a reference material for you. Okay, does that make sense? So I refer more to the picture. So we have 3 salivary glands. We have a large parotid gland and smaller sublingual and submandibular. So sublingual is under the tongue. Submandibular is under the mandible, the lower jaw. Those glands are called extrinsic, multicellular glands. We also have intrinsic, unicellular glands that I cannot show you because that's one cell. Each gland is one cell. They are in your cheeks, tongue, and lips. Buccal in your cheeks, lingual on your tongue, labial on your lips. They also produce saliva. Now these unicellular glands produce the enzyme that is called lingual lipase. What is the function of a lipase? Breaks down which stuff? Lipase. Fat. Breaks down fat. So breakdown of fat starts in your mouth. Okay? First molecules are being broken down in your mouth, right? What else does it have? The saliva. What is the major component of saliva? Water. Enzymes, by mass, it's water. Hands down. Of course, some electrolytes. We can't have them without electrolytes. Then, kind of relevant, 2 enzymes. Lingual lipase. Okay, we talked about it. I'm going to highlight them. Lingual lipase and salivary amylase. Amylase is the enzyme that breaks down carbohydrates. If you bite a piece of bread and will start to chew on it for a really, really long time, which taste do you are you going to feel? It's going to be sweet. Why? Starch will be broken down all the way to glucose, and that glucose you will taste it as sweet. Like, you have to spend really quite a time to chew, but you will sense it, right? That's amylase. So in the mouth you start to break down fats and carbs. Proteins remain intact so far. Okay? Contains mucin. Mucin is the protein that is a major component of a mucus. It's sticky protein. Okay? So it makes the pieces of food, the crumbles, okay, stick together, forming a bolus, right? Contains lysozyme, antibacterial protein. It contains antibodies, secretory antibodies. Lysozyme and secretory antibodies protect against infections. Okay? Since saliva contains a lot of water, it cleans your teeth. Now, based on the information that I told you, imagine somebody had, God forbid, cancer. Not necessarily cancer of a salivary gland, but some cancer facial. It's so-called head and neck cancer. And the big chunk of salivary glands got removed. So what's going to happen to production of saliva? It's going to go down. What's going to happen to the teeth? They're going to rot for several reasons. First, no washing action. Second, you have much decreased lysozyme and IgA concentration, so bacteria that cause caries, the dental caries, they will thrive. Does that make sense? And it's true. And that's what happens. People have enormous problems with teeth. What else? What are they going to have problems with? Huh? Dry mouth is probably going to be the least of the problems. Well, be more specific. Okay, so breakdown of carbohydrates, but you have some other enzymes down the road. Think about, you swallow the chunk normally. Now the food that enters the mouth will not be able to form that chunk because there's no saliva. So like you will have to swallow a lot of little tiny beads, which is kind of a pain in the butt by itself. And then digestion problems, of course. So it's really a problem. Okay. Now, saliva is produced as any other liquid in the body. What is the ultimate source of all other fluids in the body? Which fluid? Blood, right? Blood. Blood gives you fluids. Urine is produced from blood, sweat is produced from blood, saliva is produced from blood. Pretty much you have cells. Here you can see mucous cells and you can see serous cells. So mucous cells produce mucin, serous cells release water. They pretty much separate cells of the blood and proteins of the blood from water. Does that make sense? So you have a production of saliva and it's regulated by parasympathetic nervous system. Normally is under parasympathetic control. So when you eat something, remember rest and digest. That's your parasympathetic. When you digest, you produce a lot of saliva. Okay? Now, what is the stimulus for production of saliva? F word, 4 letters. Food. Okay? Think about food always. What happens when you are under stress? Like you have to give a presentation. Slows down. What happens to the production of saliva? Goes down. What do you feel before the presentation? Dry mouth. You have dry mouth and saliva is kind of viscous. Okay? I'm not so much worried about my interaction with you, but when you talk, you constantly kind of evaporate water, so that's why your mouth is dry, right? Another reason why saliva gets so thick and the amounts become smaller, sympathetic stimulation leads to the constriction of blood vessels in the salivary glands, which decreases the blood flow through the salivary glands, which decreases the amount of saliva produced. Make sense? Salivary glands are the site of the disease that you know as parotitis. It's a viral disease. In my home country, the literal translation of the name of the disease is the piggy face, which is kind of true. For a long time, parotitis, the swelling of mostly parotid glands because they're biggest, swelling of the salivary glands due to the virus infection was very, very common. I bet most of you never saw it, ever. The reason for that is that we have highly effective vaccine against parotitis. It's a component of MMR, measles, mumps, rubella. Mumps is parotitis, another name for parotitis. Generally speaking, in kids, it's just high fever, swelling of the glands. They're sick, they're cranky. Although in boys, this infection can spread to the testes, cause inflammation in the testes, and that inflammation is called orchitis. Orchitis may lead to infertility, and actually it's pretty often as a complication of mumps. No, completely different. No, just inflammation. So orchitis, appearance of testes does not change, but they become very painful and tender. Other complications, more rare. In females, it can be inflammation of the ovaries, ovaries, and it may cause to CNS complications, inflammation of the brain and meninges. Again, easily preventable. Teeth. So we start with none when we're born, then we grow deciduous teeth. You can see the deciduous teeth in numbers of 20. They start from the front, from the incisors. Incisors are the first. Then you have canines. Then you have molars. Among deciduous teeth, there are no premolars. Okay? So we have incisors, canines, and molars. Then eventually, and look, these numbers, they're very, very different. These numbers are very, very different. In terms of the age when we grow certain teeth, they may vary a lot. So eventually, deciduous teeth are replaced by the permanent teeth. Again, incisors, the first, canines, then premolars, and molars. So we have 4 incisors, canine, 2 premolars, and 3 molars. Function of incisor: cutting it out, okay? Cutting pieces of food away. Canines, tearing it apart. Canine means like from dog, okay? And premolars and molars, crushing, grinding, okay? So teeth are sitting in the gums, obviously. So you can see a gum here. Gums themselves, composed of the dense connective tissue, but covered on the outside with a stratified squamous epithelium, which kind of makes sense, because there's a lot of rubbing involved. Correct? So far, so good, right? So we start with 20 deciduous, we end up hopefully with 32 permanent. In some people, third molars, the wisdom teeth, they never actually grow. So it's pretty normal. Yes? Sometimes when they're coming out, you mean getting out of the gum? Yes. You're lucky, because sometimes they just pop a little bit and stay this way. Because in some people, when they try to pop, it's extremely painful, and they actually have to do a little surgery to open up the gum to let them out. But no, not necessarily. They may not come out completely. Okay? Do you understand the tissue part? So dense, irregular connective tissue, the gums that cover pretty much the alveolar processes. So you have gums, here's dense connective tissue, and this is the epithelium. Non-keratinized, stratified squamous with layers. Yes? Oh, come on. Of course not. Look, it's in one kid it's going to be 6 months, and another kid it's going to be a year. No. You should know that frontal, the anterior ones, appear before posterior. So it goes from incisors to canines to molars. Okay, that's about it. Now, the internal structure, enamel, is the outer layer of the tooth. It's the hardest material in the human body. Really, really hard. Very sensitive to acids. Then you have a layer of dentin. Density-wise, structurally, it is close to the bone. It's as solid, as tough as the bone. And then deep inside, you have a pulp cavity, which is filled with pulp connective tissue. Inside of the pulp, you can see the blood vessels and nerves. On this picture, blood vessels are red and blue, and nerves are yellow. So when, God forbid, somebody develops caries, okay, it starts with destroying enamel, destroying enamel. You don't feel anything at this point. You get to the dentin, not really. When finally inflammation, well, the caries reaches the pulp cavity, patient develops pulpitis, inflammation of the pulp cavity. Inflammation of the pulp cavity means your nerves are right there, so you're going to feel it. And that's not the worst part. You have blood vessels there. So that inflammation, the microbes that are there, if they enter the bloodstream and spread to adjacent tissues, you may have infection of adjacent tissues, especially if it's upper jaw, because what's next is the brain. And sometimes infections of the, they may produce like a cyst, and if cyst opens up and microbes enter the meninges, yes. Pretty much what they do, my mom worked as an administrative assistant in the dental clinic, so I saw a lot. I was famous in the clinic because I fell asleep when the doctor was doing my root canal and I beat her. I fell asleep and I closed my mouth. And she told me, we have to finish, it starts to bite. So this thing is inflamed. They clean up everything from here. Okay? Well, they kill it first. When they do the root canal, they put something, I don't really know what drug it is. It pretty much kills the nerve. So when they finally get to the root canal, all they scrape is the dead tissue pretty much. And then they feel it, so they scrape all the organics, and that's the most important part. Because if any part of tissue is there, and they feel it, this part of tissue can start to become necrotic and inflammation, and then you have to redo the root canal, and it's kind of not something that you want. Okay? That make sense? Explain? Good. The tooth is attached using cement to the periodontal ligament, and periodontal ligament attaches the tooth to the jaw. To remind you, remember, that's the joint. That's the movable joint that is called gymphosis. We have 32 gymphotic joints in the body. Tooth sits in the jaw pretty well. When somebody loses the tooth, it is usually just the crown part. Oh, that's we didn't talk. So the upper part, the part of the tooth that you can see is called a crown. The part of the tooth at the level of the gums is the neck, and here is the root. Does that make sense? So if you ever had your molars removed, you know, when the dentist pulls them out, he almost puts his leg in your stomach to kind of rip it, okay? Because they are touched pretty tightly. And I was lucky enough at the age of 8 years, I fell from the fence and lost the front tooth, which was a permanent tooth. And when I came to the dental clinic next day, they were shocked because they said, I lost the entire tooth. It wasn't broken. It fell out completely with the root. And they told me, dude, that type of mechanical impact should have given you a concussion. for some reason, it was some kind of fell in a weird way, probably. Okay, I was complaining that I'm now disabled. At 8 years of age, I thought I was disabled. They said, "You're not disabled. You're just ugly." So yeah, it's really hard to lose the tooth. Yes.
So is that like if you do get like a tooth pulled and they shimmy and do whatever they do, and when you like, not that you like, not, you don't hear it, but it's like a cracking almost like sound. Is that like it's separating from the ligament then? Is that what that is?
So first of all, sometimes when they try to pull the tooth out, they may separate the crown of the tooth and the root, and then they have to pull out the root. So they kind of put the screw in and pull it out using the screw. It's really a pain in the butt. Okay, and now they start to feel out what they do sometimes. Now the dentists offer, when they pull out the tooth, you have a huge gap, and it's not really good to have that huge gap because it may deform the alveolar processes of the bone. Sorry. So what they can do, they can put collagen filling inside of it, so have some material that fills up the gap, and you can put implants in there later. Okay. No, I have a bridge. I have a bridge. It was really hilarious when I was a child. I had to wear the removable thing. It's like a removable jaw, but just one tooth. And I got really used to it. So I played with it using my tongue. And people often were scared when I smiled and I had like 3 layers of teeth instead of 2. They were freaked out. It was really funny.